Good morning, everyone. Welcome to the live Zoom webinar. The topic for today is extraction, bone resorption, and implant site development. It is organized by the Regeneration Hub Pune. And we are delighted to have you join us for this insightful session led by Dr. Nihal Devkar. He is an MDS periodontologist and he's a certified expert in oral implantology. And also he has a 20 years experience of uh, academics. Let me just give you an insight of the Regeneration Hub. It is situated in Pune. It is a specialized dental implant center committed to having advanced science and practice of implantology through a comprehensive approach that integrates clinical excellence, education, and innovation. The center focuses on enhancing patient outcomes and evaluating professional standards in implant dentistry. The course in July. So anybody, whoever is interested, you all can contact on the numbers given below. I will hand over the further details and the session to Dr. Devkar.
Good morning, everyone. Thank you, Dr. Preeti. Now, we have two clinical scenarios out here. The one on the left side where the patient has reported after a long history of edentullism. And as you can see, two implants have been planned, and due to the ridge deficiency in width, some augmentation regenerative approach is required in this particular case. And that is expected after long history of edentullism. On the right side, we have a case, a young patient where root piece is present and some treatment plan has to be there. Of course, without any doubt, the first thing we all must plan is whether to save the tooth. As a periodontist, we always strive to save the teeth first. And endodontic opening is mandatory, whether it is root canal or post and core or by doing some crown lining procedure. If this tooth can be saved, well and good. But today we are restricting our discussion to how the particular ridge preservation can be done for the sake of implantology. To understand this process better, we must go into the literature a little bit and take the help from the literature, and so that our patients are benefited. Now, we all are aware about the alveolar process. What is alveolar process? It's basically socket that surrounds the root of the teeth. Here, as you can see, there is a green line. Okay, similarly, it is depicted on the radiograph as well as on the histological section. The green line differentiates the alveolar process from the basal bone which is on top, alveolar process which is coronally placed or below this line. Similarly, in radiological section, the root surrounded by periodontal ligament and the alveolar process. We are aware about what happens after post-extraction. Once the tooth is extracted, right, within immediately there is hemostasis, the clot fills up. The hemostasis is due to presence of platelets, WBCs, RBCs all together. Then after within few weeks, the inflammatory phase starts where neutrophils and macrophages come into the picture. And there is formation of the granulation tissue. And later on, it moves into the stage of proliferation and maturation. So the woven bone formation starts at some around 4 to 8 weeks from the base and later on shifts to the coronal part. And this woven bone, when it becomes mature, okay, that is, it takes somewhere around 20 weeks. So are we going to wait for the placement of the implant for that long? No. So what exactly can we expect that happens inside the socket as well as the outside portion of the socket? So let's see what happens in the intra-alveolar healing of the socket. So I'm quoting few of the landmark studies in this particular reference or in this particular section. So one of the studies conducted by Cardaropoli in 2003, what they did was they studied the healing of marginal, central and apical portion of the extraction sockets. And 9 dogs were used or rather sacrificed. The biopsies were taken on 9 different days. These are the days that are mentioned, like 1, 3, 7, and so on. So what they observed is intra-alveolar healing. Initially, as we expect, is formation of the coagulum, then after granulation tissue, then after formation of the provisional connective tissue matrix at 7 days, woven bone formation at around 2 weeks, mineralized bone at around 1 month, and finally bone marrow around 3 months. After intra-alveolar healing, let's see what happens at outside the socket, that is extra-alveolar healing. So this is again one of the most famous study conducted by Araujo and Linde in 2005. They studied the dimensional alterations of the alveolar ridge that occurred following tooth extraction, as well as the process of the bone modeling and remodeling associated with such change. What they did was they extracted or hemisected 4 premolars, and they observed the healing at 1, 2, 4, and 8 weeks. So at 4 different levels. These levels were located at 1, 3, and 5 millimeter apical of the buccal and lingual bone crest. They had very interesting finding. As you can see, the histological sections, buccal is on the right side and lingual or palatal plate is on the left side. And what happens inside, as you can see, there is coagulum, there is provisional matrix formation, then there is woven bone formation. And you can see the references of 1 week, 2 week, 4 week, and 8 weeks. Most critical observation was these 2 lines, the yellow line and the blue line. The yellow line, it signifies the lingual plate, and the blue line, it signifies the buccal cortical plate. Okay, as you can see, over a period of time from 0 to 8 weeks, there is a significant drop or rather reduction in the buccal plate height. This particular height, the measurement was somewhere around 2.3 millimeters. As we all know, implantology, it's about dealing with millimeters. Okay, we have our standard implant size of somewhere around 4.5 millimeters, and height somewhere around 12 to 13 millimeters. So if this particular width especially is compromised by a few millimeters, we are forced to go for more complex procedures like augmentation. One more important study conducted by Chapuis in 2013, they conducted it on 39 patients on single tooth in anterior maxilla. And what they studied was they did CBCT at post-extraction and 8 months. The result they observed was in case of a thick phenotype, that means thick bone, which is more than 1 millimeters, the vertical bone loss was 1.1 millimeters. Whereas in case of thin phenotype, that is these upper ones, with the cortical plate thickness was less than 1 millimeter, the vertical bone loss was quite a lot, that is 7.5 millimeters. As you can see, this is huge. So let's see more towards the histological portion of why this particular resorption happens. Again, into the same picture, which is followed from radiographic, histological, and details of this particular section. When you observe this, we see that there is periodontal ligament and there is alveolar process. The alveolar process is further divided into the immediate part that is close to the periodontal ligament is alveolar bone proper, and the main part of the alveolar process. This alveolar bone proper has insertion of bundles of the periodontal ligament. This particular bone, or rather mineralized portion, is known as bundle bone. It is a thin mineralized bone without medullary spaces. It is considered to be a mineralized portion of the periodontal ligament rather than being part of the alveolar process itself. Okay, there are controversies about each and every topic. Similarly, on this topic also, few people say that it is not a part of the alveolar ridge, but it belongs to the deep periodontium, and it is in direct contact with periodontal ligament fibers. Hence, it is resorbed after extraction. Another study, Schropp conducted in 2003, they observed the healing and soft tissue contour changes following single tooth extraction. What they observed was soft tissue and bony contour changes on study casts when the baseline alveolar ridge was 12 millimeters, whereas it was 50, but there was 50% reduction of the ridge width. That is, it came down to 6.1 millimeters after extraction, of which 2/3 occurred during the first 3 months of healing. As you can see, this is the critical period
यार आपका ये रूम में ना सच
of
में
healing.
मैं क्या बोलूं यार, मैं तो जीवन मेरा बीत गया
Next,
आपके साथ 18 साल, पता नहीं कितने साल हो गए, आप कभी सुधरे नहीं यार।
next we
बहुत
have
गलत
a
बात।
study conducted by Hammerley and Lang, the systematic review by Lang. It shows that the alveolar ridge undergoes following dimensional changes within 6 months after tooth extraction. The mean horizontal ridge reduction has been calculated to be somewhere around 3.8 millimeters. So if the ridge width, as it is in Indian population, the ridge width is not great, especially in maxillary anterior areas, we get somewhere around maximum 6 to 7 millimeters in posteriors. In anteriors, we hardly have anything. So if there is a reduction of this much, okay, we are forced to go for augmentation procedures, which is again more complicated. So this socket alteration, whatever changes are happening, resorption is happening, it is known that it is larger in molar areas, but it is critical in anterior areas due to aesthetic demands. Also, the studies have shown that the thicker the facial bone, the less is the resorption. Also, non-molar sites are associated with an increased need for additional bone grafting procedures prior to or at the time of implant placement compared to molar sites. Okay, as I mentioned, especially in Indian scenario or more in anterior areas, whether maxillary or mandibular areas, normally they need some additional form of bone grafting procedures, either during or prior to the implant procedures. So the lesson from all these, majority of these studies for us is do not extract any tooth or rather tooth which is indicated for extraction unless your implant planning is done. You can keep the root, you can prescribe antibiotics, or if at all there is no pain, you can keep the tooth, you give a provisional unless until you're very sure about what implant planning you want to do, what provisional or what temporization you want to do for this particular tooth or this particular site or multiple sites they could be. So this all has been dictated by the previous studies. Similarly, there is a society known as ITI, International Team of Implantologists, that has given the classification of the implant placement. Again, this is based on the healing of the sockets. They have classified into immediate implant placement, that is on the same day of the extraction, early implant placement, that is within 4 to 8 weeks, where you have majority of the soft tissue healing that has happened. Then you have further early, that is somewhere around 12 to 16 weeks, where you have partial bone healing, and delayed, where there is somewhere around more than 6 months of healing. So obviously, are we going to wait that much? Because now from the studies, we know that there is a lot of resorption that is going to happen, especially in the first 3 months, forget about 6 months. So there is no need to wait for that until patient is not available or due to some systemic contraindications. So your first target should be to go for immediate one as much as possible. If not, at least the next target, that is early placement of soft tissue healing or partial bone healing. The protocol currently that is followed is the socket should not be empty. Okay, for all these alterations, if you don't want them to happen, the socket should not be empty. It should be either filled up with implant or with a biomaterial or both. Even immediate implant along with the placement of graft material is considered to be some form of socket preservation method. So that takes us to different procedures that can be indicated. This particular webinar or presentation is not about details of these procedures. It's a very short topic, and we are not going to give too much of time to the procedures known as immediate implant. There are some socket grafting procedures, partial extraction therapies, as well as if they don't succeed, then obviously you don't have the choice but to go for ridge augmentation and sinus lift procedures. Now, ridge augmentation, again, it's as I mentioned, it's not a clear cut absolutely to be, it has to be mastered. You need to practice it a lot. You need to deal with the flap raising, release, and proper suturing of the flaps. As a periodontist, I can proudly say that they are one of the best to deal with these procedures, since they deal with raising of the flap and splitting of this periosteum, separation of the periosteum. So if you're beginning into this procedure and starting out, please do call a periodontist for these kind of procedures, and you can learn from them. All right. But at the same time, there are certain procedures you can learn on your own instead of augmentation or lifts, sinus lifts, or some ridge split procedures. You can think about these procedures known as socket grafting. So what is socket grafting? Another name for this is alveolar ridge reservation, ARP. It basically involves putting a graft material into the alveolar socket. Different types of biomaterials are available. They all have been used in a variety of studies, and they're combined either with or without immediate implant placement. Now, we are not going to the details of implant placement and jumping distance, how much to graft, but there is a concept of that. Also combine other biomaterials such as barrier membrane. You want to close that socket so that the graft material that you put doesn't flow out of the socket, to replace a lost socket wall or soft tissue substitute to cover the socket entrance. What are the indications for this socket preservation or socket grafting? When there is delayed implant planning has to be done, patient is not willing to go undergo implant right now. Then when immediate implant is not recommended, it could be due to the reasons that some hardly any bone is available beyond the root apex and immediate implant is not possible. When primary stability cannot be obtained for the implant during your immediate implant placement, and extraction sites that present a thin buccal bone plate that is less than 1 millimeters, where extensive post-extraction resorption and dimensional loss of the alveolar ridge should be anticipated, and it may jeopardize the implant placement. Also, when there is reducing the need for the sinus lift. In case of maxillary posteriors, if after the extraction, if you're very close to the sinus, it is better to graft the site, leave it for healing, and maybe you can attempt the implant placement later on, maybe with or without the sinus lift procedure, but that will be anytime much easier for you. So few concepts about the alveolar ridge preservation. I again quoting few more studies. You can take the reference for your reference, all these studies. So it is a more effective procedure than unassisted socket healing. That means if you allow the socket to heal on its own, so as compared to that, ARP has been shown to be more effective in preserving the ridge dimensions and contour. They have limited benefit, however, on new bone formation when compared to naturally healing sockets. This ARP or socket preservation, it reduces not only the indications, but also the extent and complexity of additional bone augmentation procedures at the time of or prior to implant placement. So that's a huge benefit of this ARP when you don't have to, your quantity of your additional bone augmentation also reduces. Something that may be of substantial clinical benefit, especially to a new beginner, okay, in the field of implantology. So what do you use? You also use a barrier membrane over a graft or substitute has been proven as the most predictable current protocol for socket grafting. Few more studies and their conclusions. They have shown that horizontal resorption of just over 1 millimeter will still occur with relative preservation of the vertical bone, whereas the lack of socket grafting, that means if you don't do, what will happen, that also has been studied. It will result into more than 3 millimeters of horizontal bone loss and at least 1 millimeter of vertical bone loss. Usually, implant surgeries can be performed after once you complete the socket preservation procedure. You can perform the socket implant placement after 4 to 6 months with results like those achieved with implant inserted in the native bone. The disadvantage, however, is obviously because you need 2 separate procedures. The first one, you will be extracting it, putting the graft and closing the socket using some material, and second appointment after 4 to 6 months will be for the placement of the implant. Another study that has mentioned that socket grafting, it prevents horizontal as well as vertical bone resorption by these measurements, somewhere around 1.9, let's say around by 2 millimeters. Most favorable outcomes have been observed with the use of xenograft, okay, that is animal source, as well as from the allograft, which is covered with a resorbable collagen. Also, sites with buccal bone thickness of more than 1 millimeter have shown favorable socket grafting outcomes. Let's go through briefly with the key steps of this socket grafting or alveolar ridge preservation. The first one automatically is that you want to extract the tooth, or traumatic extraction. You need to degranulate. You need to irrigate the socket. If possible, bleed the socket, graft it, close it with a membrane, and suture it without any tension. Let's go to the first part, that is minimally traumatic tooth extraction. Most important criteria is doing a minimally, specially traumatic and flapless approach has to be there with using different instruments like periotomes you can use, and if possible luxators you can use for this minimally traumatic tooth extraction. However, sometimes if you also want to go ahead with immediate implant, you might have to do some soft tissue procedures that I've just mentioned for the reference. You can do de-epithelialization of the circular tissue. Okay, any soft tissue, sometimes you need to do connective tissue harvesting and graft, because majority of the immediate implant cases, there is post-operative or rather after a few years, there is typical buccal recession, soft tissue recession. So to avoid that, it is better to do the soft tissue augmentations. So after the tooth removal, this alveolar socket is debrided of all the granulation tissue using curette or piezo. you can stimulate the bleeding from the osseous wall with a rotary instrument, which stimulates the new bone formation and graft incorporation. Once this cleaning is done, you examine the socket carefully, visually, tactile. Use a simple periodontal probe to check the bone morphology. Also do with direct visualization. This can identify any fenestration or dehiscence defect that are present inside the socket. Also, you can check for label and palatal plate thickness, whether it is adequate or no. Ideally, it has been shown by the research that the thickness of 1.8 millimeters is a critical thickness. Ideally, anything lesser than that, you should be grafting or augmenting. Next procedure is using the biometal or the graft. If the socket wall is intact, you can place the graft material inside the socket, cover it with either a collagen membrane, collagen plug, or polytetrafluoroethylene membranes. And you can do a crisscross suture on top of that so that the graft membrane stays and also the membrane. You can also use a provisional prosthesis, okay, because the extraction has been done, especially if it is anterior, patient will ask or a patient will need a prosthesis. It would also protect the graft material. Also, in case if the patient is having some form of fenestration, okay, you need to create small pouch around the defect, whether use a resorbable or non-resorbable membrane, and place it some little bit beyond the defect. You can keep it for around 4 to 6 weeks. So we are almost close to the presentation. We'll only show a few videos, one on the model where a simple ARP procedure or socket grafting procedure will be shown on the demo model, where certain graft, xenograft and a collagen membrane is used for the preservation, socket preservation of 2-4. Okay, you can see the extraction has already been done. We'll proceed with the socket preservation. In the second video, we'll be showing you a case, a clinical case of socket preservation. So let's go through this video. So this was one of the socket preservation procedures. And next is one of the clinical case that is again on the maxillary premolar area or maxillary premolar site. In this particular case, we used a different technique known as ice cream cone technique, and that is the reason because there was some midfacial osseous fenestration in this case, and that was detected on CBCT prior to the extraction, as well as with the help of bone sounding procedure done using a fine movement of the periodontal probe. So once this a traumatic extraction was done, debridement, granulation tissue, you need to irrigate a lot. Okay, you can finish literally 2 syringes of normal saline. Make sure you debride everything. All the granulation tissue should be cleared off. And then after you can, if possible, you can bleed the socket a little bit and proceed with the grafting. If there is adequate blood, there is no need to bleed the socket extra. We can pack it and use a simple membrane on top of it and suture it using either horizontal matrix suture if possible, if you're trained into it. Otherwise, give a simple interrupted suture, that should also be enough. So name of the technique is only because of the shape of the membrane that is inserted inside the socket in the form of a cone. That's all, nothing flashy about it. So let's go through this particular technique. Right. Thank you so much. Thank you, Dr. Mahesh and Dental Discussion and Jobs Group for having me here. It was a pleasure, and hopefully we'll all can reconnect again later on for any such small topics. All right, Dr. Preeti, you can take over. Thank you so much.
It was a very insightful presentation, sir. So we have, I think most of the people might have those questions. So there are two questions that I would like to ask you, that which are the materials that we use uh, during
For the process
for the
of
process?
socket. Because of the time constraint, I did not include that slide, but the literature has included all possible biomaterials, right from autograft, xenograft, allograft, alloplast as well. And all possible combinations have also been used for these simple procedure of socket grafting. When it comes to ridge augmentation, you need to, of course, rely on majorly on autograft and xenograft combination. But out here, you can play around with a simple, depending on the budget, of course, of the budget of the patient. You can use any of these biomaterials, and a simple collagen membrane should also be enough.
And I would also like to ask, what are the instruments that we should use during the processes?
All right. As I mentioned, your first primary target should be to do with any flapless or traumatic extraction. If possible, you can use a periotome. If you have any tunneling instrument, you can use that instrument to create a small tunnel on facial as well as lingual side without raising the papillae. Okay, don't disturb the papillary blood supply. And then after usual biomaterials for grafting, for extractions, you can use normal luxators and forceps. You need normal saline to irrigate the wound, curate to debride the area, and later on for closure, you might need a monofilament suture material to close the top of the wound. That's it.
Thank you, sir, for this presentation and the webinar you conducted. And anybody who's interested to attend the workshops, you can contact. The details have been displayed previously.